Welcome everyone, Dr. Lindner. What we're going to be covering in this lecture is the appendicular skeleton. We've already covered the axial skeleton. In this video, we'll talk about the appendicular, but primarily focus on the upper extremity. So in this picture here, what we see is the shoulder girdle, right? Not the shoulder joint, but we see the shoulder girdle. When we talk about the shoulder joint, we're talking about primarily the glenohumeral joint, which is the junction between the scapula and the head of the humerus. But the shoulder girdle incorporates this bone here, the clavicle, and how the clavicle is it acts like a strut bone that keeps the scapula on the posterior rib cage. Because if this bone wasn't here, if the clavicle wasn't there, the anterior muscles that go from the manubrium, the ribs, and attach to the coracoid process of the scapula, primarily pec minor, it would pull the scapula to the anterior portion. So this clavicle acts as like a strut or a strut bone separating. You can see that there's a medial attachment right here, where the medial portion of the clavicle articulates with the sternum. This part of the sternum is called the manubrium. And then the lateral end attaches to the scapula. And this highest point of the scapula right here is called the Acromion process. So when we look at the clavicle, we'll see that on the top, the medial portion is called the sternal end because it makes a joint with the sternum. It's referred to as the sternoclavicular joint, the sternoclavicular joint. Then at the lateral end, which is here, it's called the acromial end because it articulates with the acromion process of the scapula, which is the highest point of the scapula. This joint is typically referred to as the AC joint. AC stands for acromioclavicular joint, the acromioclavicular joint. So the top view is looking at it from the superior perspective, looking down, and the bottom picture is the inferior view. And when you look at it from underneath, there are a few roughened sections for ligaments to attach. Remember, ligaments go bone to bone. So there's a conoid tubercle, and there is a costal tuberosity here. Okay. Notice that the medial 2/3, if you even palpate on yourself, right, this is anterior, here is posterior. So the anterior 2/3 from here to here is convex. It's convex. And then the lateral 1/3 here is concave. And the reason why this concavity is significant is because the concavity is right here. And once you find this deepest part of the concavity of the clavicle, which is here or here, and you drop inferior to it, it takes you to this bony prominence of the scapula called the coracoid process. Coracoid. Not to be confused with the structure that we'll look at today called the coronoid. There's a coracoid process, and there also is a coronoid process. The coracoid is on the scapula. The coracoid is on the scapula. The coronoid is on the ulna. And there's another coronoid that's also on the mandible, if you remember when we covered the skull. On the top of the manubrium is a notch called the jugular notch. And then we also remember between the manubrium and the body of the sternum, there's this sternal angle or angle of Louis, which is an important landmark because it takes us to that second rib. And once you find the second rib, if we move down a finger breadth, we're at the second intercostal space, then the third rib and the third intercostal space. And whenever we're listening to lung sounds or heart sounds, we always want to place the diaphragm or bell of the stethoscope on the actual intercostal spaces, not on the bone, because the bone will obstruct the sound. Okay, so there's just a close-up look. Here's the jugular notch, here's the clavicle, here's the scapula. This is the humerus. These are the ribs, and these are the intercostal cartilage. Again, this is the sternal end, and if you look at the medial end, it does look different than the acromial end. The acromial is wider, and it has more of a flattened appearance to it. And there is a flattened smooth surface here called a facet, and that facet is for the articulation with the acromion process to make the AC joint. We can see here the acromial end looks very different than the sternal end. The sternal end also has a facet for it to articulate with the manubrium. On the inferior view, we could see the conoid tubercle, and that's for the conoid ligament that will attach to it. Okay, now this is a very important bone called the scapula. The scapula has lots of landmarks associated with it. And I want you to be comfortable with it, but the first thing that we have to do is look at the scapula, and your first question you have to ask yourself is this: am I looking at this from the anterior view, or am I looking at it from the posterior view? So the way you tell that we're looking at it from the anterior view is from the anterior, it's very smooth. The entire anterior body is very, very smooth. But if you look at the posterior, we have this structure that interferes with the body of the scapula. This structure here is called the spine of the scapula. The spine of the scapula. It says spine. If you ever ask this on an exam, don't put spine. It's the spine of the scapula. Make sure you're clear, because the spine is the vertebral column. So this is the spine of the scapula. When you look at it from the ventral view or the anterior view, this whole entire surface is nice and smooth. This smooth portion is called a fossa, and it's called a subscapular fossa. When we look at the posterior portion of the scapula, this landmark that goes from the medial border of the scapula, notice that it goes kind of on a diagonal. As it goes laterally, it also goes superior and lateral. That's the direction of the spine of the scapula. If you look at the spine of the scapula, it starts here at the medial border. Now, if there's a medial border of the scapula, there's got to be a lateral border of the scapula. And there's a superior border of the scapula. So these lines are really kind of easy: medial border, superior border, and lateral border. Notice that the spine of the scapula starts at that medial border, and it goes superior and lateral till it takes us to the very highest portion of it, and that is the acromion process. That is what we call the acromion process. So on the posterior view, if you see the spine of the scapula, that tells us we're looking at it from the back. That's the first question. The second question you ask yourself is, where is the glenoid cavity or the glenoid fossa? Which is, when you look at it from the lateral view, it's right here. This glenoid cavity or glenoid fossa is the smooth depression in which the head of the humerus will articulate with. That's over here. From the anterior view, it's here. And on the posterior view, it's here. Okay. So once you find that glenoid cavity, we know, or glenoid fossa, we know that that has to be on the outside or the lateral portion of the scapula, because the head of the humerus and the arm has to articulate, and we know the arm is lateral, can't be here on the inside. So once you find the glenoid cavity, which is this border is the lateral border, and the border on the inside is the medial border. Another name for the medial border, since it is closer to the spine, it's called the vertebral border. So the medial border is also known as the vertebral border, whereas the lateral border, since it's closest to the armpit, it's referred to as the axillary border. Axillary border. Remember, the axilla is the armpit. Okay, so we've covered the superior border, medial border, lateral border. We also have a few angles. This angle here at the top on the left, that's called a superior angle. And if there's a superior angle, there's going to be an inferior angle. Okay. Now, we have some fossas, right? A fossa is a smooth depression, and there's going to be muscles that attach there. Wherever there's a fossa, there's going to be muscles that will attach. Now, when we go to the posterior view and we find the spine of the scapula, there's a smooth depression above it, and then there's a smooth depression below it. Once we find the spine of the scapula, the depression above it is called the supraspinous fossa. And then the fossa below it is the infraspinous fossa, right? So this spine of the scapula is a real important landmark, because once you find it, we can go, all right, well, it begins here at the medial border. It goes superior and lateral, takes us to the highest point, the acromion process. There's a fossa above it and a fossa below it. The fossa above the spine is called the supraspinous fossa, and the fossa below it is the infraspinous fossa. But I said there's 4 fossas on the scapula. That's 1, that's 2. The third is the glenoid fossa, which is also referred to as the glenoid cavity. That's known as the glenoid fossa. Now, it's very shallow. It's not a very deep articulation in relationship to the head of the humerus. The head of the humerus is much, much bigger than the glenoid cavity. Since you have a large head of the humerus articulating with the glenoid fossa, it makes a very unstable joint. And because it's unstable, we have lots of soft tissue structures like muscles, like the rotator cuff muscles, to stabilize this joint. So we have supraspinous fossa, infraspinous fossa, glenoid fossa, aka glenoid cavity, and the 4th fossa is on the anterior side. It's all of this. All of this is called the subscapular fossa. Subscapular fossa. Okay. So the body, like if I pointed on an exam and I pointed to this, I wouldn't say body of the scapula, because there's also a body here on this side. I would pay attention to the fossas. If you see an indicator or a dot or an arrow on the anterior scapula, I'm trying to differentiate to make sure that you know that's the subscapular fossa. If we put one here, it's the infraspinous fossa. If we put one here, supraspinous fossa. And if I put one here, glenoid fossa. Okay, so as you're studying this, I would kind of, in my mind or on a sheet of paper, I would say, what are the 4 fossas? Do I know the 4 fossas? Then I would say, do I know the three angles? There's three angles. There's a superior angle, inferior angle, and a lateral angle. The lateral angle is associated with the glenoid fossa. Then I'd say there's three borders. There's a medial border, also known as the vertebral border. There's a lateral border, also known as the axillary border. And then there's a superior border. So we have four fossas. We have three borders. We have three angles. And then we have two large processes. The two large processes is this one here in the front, called a coracoid process. And then the second one is the acromion process. The acromion process is the highest part. The coracoid process projects anteriorly, and it's an attachment site for many muscles. What attaches to the coracoid process is your pec minor. The pec minor muscle attaches here. Another muscle called the biceps brachii, but it's the short head of the biceps brachii. And then there's a third muscle called the coracobrachialis, the coracobrachialis. And if you look at the word coracobrachialis, this muscle is named by its origin and insertion, meaning where it begins and where it ends. Coraco, because of the coracoid process. Coracobrachialis, brachium means arm. So it's going from the coracoid process to the humerus, which is the arm. Then we have two tubercles. Tubercles are really, really small little bumps. There's one on the top of the glenoid cavity, and there's one on the bottom of the glenoid cavity. The one on the top is called supraglenoid tubercle, and the one on the bottom is the infraglenoid tubercle. The supraglenoid tubercle and infraglenoid tubercle are also important landmarks because there's muscles that are going to attach there. When we do muscles, we'll cover them. But the long head of the biceps originates here, and the long head of the triceps originates here. These fossas are important because there's rotator cuff muscles that attach here. The supraspinous fossa is the origin for a muscle called the supraspinatus. The infraspinous fossa is where another rotator cuff muscle originates, called the infraspinatus. So you have the supraspinatus muscle originates here, and the infraspinatus muscle originates here, and the subscapularis muscle originates here. The subscapularis muscle originates here. So it's important to learn these landmarks. The reason being is there's going to be muscles that attach there. And as we move on in the course, we're going to get to muscles. And when we do muscles, it's not just important to know the name of the muscle and where they're located, but it's important to know where these muscles originate, meaning where they begin, and where these muscles insert, meaning where do they end and what are they going to move. Okay. All right, so that's the scapula. Again, ask yourself those first few questions. Are we looking at this from anterior or posterior? And then find the spine of the scapula and the glenoid fossa or glenoid cavity. So when we isolate, and now it doesn't look as busy as it does here. Now, again, let's ask ourselves, are we looking at this from front to back? All right, well, it's smooth in the front. So right, we don't see the spine of the scapula, so this has to be the anterior view. Once we know it's anterior, we find the glenoid cavity, and we know that this is lateral, so this is the lateral border. This is the medial border. Superior angle, inferior angle, superior border. Coracoid process, acromion process, subscapular fossa. What muscle originates? On the subscapular fossa, a rotator cuff muscle called the subscapularis. Now we're looking at it from the lateral view. How do we know? Well, we see the glenoid fossa, or the glenoid cavity, which is lateral. So that means it's the lateral border. Notice that the anterior portion is a little bit concave, and it has to be because it's going to articulate with the ribs. And it's not making a joint with the ribs, right? Joints are when bone and bone come together. There's actually muscle that's here. So the muscle acts as a buffer between the scapula and the ribs. One of the muscles is called the subscapularis. Okay. Another is a muscle called serratus anterior. That's going to be the buffer between the scapula and the rib cage. So it's not really a joint. They call it a false joint, or really called a false joint, because again, it's not bone to bone. You got muscles separating it. Here's the spine of the scapula. In the front is the coracoid process, and the back is the acromion process. On the top of the glenoid cavity, supraglenoid tubercle, and on the bottom would be the infraglenoid tubercle. Now we look at this view. We say, okay, it's the scapula. We know we're looking at it from the posterior because we find the spine of the scapula. The spine of the scapula moves superiorly and lateral. As it goes superior and lateral, it takes us to the highest point, called the acromion process. Once we find the spine of the scapula, what's the fossa above the spine? Supraspinous fossa. What's the fossa below it? Infraspinous fossa. Once we find the acromion process, just go down. Here's the glenoid cavity or glenoid fossa, which is lateral. So you know that this is the lateral border, aka axillary border. On the other side, medial border, aka vertebral border. Superior angle, inferior angle, superior border. Okay, now we're going to be looking at the bone that articulates right here at that glenoid cavity or glenoid fossa. That bone is called the humerus. When we look at the humerus, we have to ask ourselves, are we looking at the humerus from anterior or posterior? Are we looking at it from anterior or posterior? Now, one of the ways that you can tell is when we zoom in here and we look at the anterior portion, there is two large bumps with a groove in between. The two large bumps with the groove in between, one is called the greater tubercle. That's one of the large roughened areas. And then the other is the lesser tubercle. And in between the greater and lesser tubercles is this intertubercular groove. The other name for the intertubercular groove is called intertubercular because it's between the two tubercles. But the other name for this that's acceptable is also called the bicipital groove. The purpose of this bicipital groove is there's going to be a tendon that travels through here. The tendon that travels through here is called the long head of the biceps, right? Biceps brachii, bi means two. There's a long head and a short head, but it is the long head that travels through this bicipital groove. So again, we have a greater tubercle, a lesser tubercle, and a bicipital groove. That tells us we're looking at it from the anterior. The head of the humerus is going to project medially. It's projecting medially in to the glenoid cavity to form the glenohumeral joint. Okay, so that's one way of telling if we're looking at it from the anterior. The other way, if we go all the way down to the distal end, There's a difference at the distal end where from the anterior, there are two fossas. One's called the radial fossa. The other is called the coronoid fossa. But if we look at the distal end on the posterior side, there's only one fossa. There's one smooth depression on that distal posterior side, and it's called the Olecranon fossa. Okay, so if you only see one fossa, you're looking at the bone from the posterior. If we see two fossas, we're looking at it from the anterior. Okay, let me zoom out here a little bit so we can look at the other structures. Now, again, when you look at the humerus from the anterior, we were able to see the greater and lesser tubercle with the bicipital groove. On the posterior side, not so much, right? But you can see the head of the humerus very clearly. You can see the greater tubercle very clearly, but we don't see a bicipital groove. We don't see a lesser tubercle. We do have a surgical neck. You can see that both, right? What comes after the head? That's going to be the neck. Surgical neck, because when there are fractures, this is where most surgeries take place, at the surgical neck. Around probably the proximal 1/3, right? When you go down about 1/3 of the way, there's a bump here called the deltoid tuberosity. What attaches to the deltoid tuberosity? It's the insertion site for a muscle called the deltoid. That's where the deltoid inserts. Now, why is it important to differentiate between anterior and posterior? Because once you discover anterior, and we know that the head of the humerus projects medially. Once you find the head and you find its medial projection, if you go inferior all the way distal, right? This is proximal, this is distal. When you go all the way to the distal part of the bone, we find a projection that sticks out here called a medial epicondyle. Again, once you find the head of the humerus projecting medially, it has to project medially because it must articulate with the glenoid cavity of the scapula. When you go distal, it takes you to the medial epicondyle. Once you find the medial epicondyle, you go to the other side, and there's a little bump called the lateral epicondyle. What's the importance of the medial epicondyle compared to the lateral epicondyle? The difference is when you palpate the muscles on the inside of your forearm, okay, and you make a fist or you squeeze your fingers, there's movement here along your anterior forearm because those wrist flexors and finger flexors originate off the medial epicondyle. So all the wrist flexors and some finger flexors originate off the medial epicondyle. And that's significant because there is a clinical condition where people get a lot of pain and sensitivity here, and they call it medial epicondylitis. Itis means inflammation. Medial epicondylitis. Sometimes they call it golfer's elbow because golfers are flexing their wrist and flexing their fingers around the golf club for hours. And when you overuse a muscle, you can get an itis. So that's called medial epicondylitis. When the muscles in the forearm along the lateral epicondyle get sensitive and painful, they call it lateral epicondylitis because all of the wrist extensors and finger extensors originate near the lateral epicondyle of the humerus. They call that tennis elbow. It could be from an improper backhand or repetitious wrist extension. So anytime you extend the wrist over and over and over, you can pull, the muscles get overused and they pull on that lateral epicondyle, causing lateral epicondylitis. Okay, so make sure you know, and also the medial epicondyle is certainly more palpable, like you can feel it more easily than the lateral epicondyle, and that's because it sticks out more. Okay, when we look at the distal part of the humerus, all the way down at the bottom, there's a trochlea, which goes from here to here, this section, closer to the medial epicondyle, it's called the trochlear, and this rounded portion is called a capitulum. The capitulum, this here is the articulation for the radius, which is in the forearm, and the trochlea is the attachment for the ulna. So these two bones, the capitulum and the trochlea, are extremely important for the forearm to attach to form a joint with the humerus. So when the radius articulates with the capitulum, it's called the humero-radial joint. When the ulna articulates with the trochlear, it's called the humero-ulnar joint. Now, because the radius articulates with the capitulum, when you flex your elbow, the head of the radius is going to fit right into this radial fossa, this depression. The radial fossa is a smooth depression for the head of the radius. This fossa above the trochlea is called the coronoid fossa. And the coronoid fossa is an articulation or a depression for the coronoid process to fit in. The coronoid process is of the ulna. Now, we haven't done the radius and ulnar yet. So when I cover the radius and ulna, we have to find the head of the radius and the coronoid process because they're going to fit in their corresponding fossas. In fact, let me just show it to you real quick here. So when we look at the forearm, here's the head of the radius, and here is the trochlear notch. So if you look on the left, here's the trochlea, right? You see this spool, this rounded structure. So this trochlea is going to fit perfectly in this trochlear notch. Here's the trochlear notch. Now, if you look right here, this little tip is called the coronoid process. This coronoid process of the ulna is going to fit perfectly here in the coronoid fossa. That's when you bend your elbow. When you bend your elbow, they're going to meet. Here is the head of the radius. When you bend your elbow, the head of the radius is going to move smoothly around the capitulum and attach right here to the radial fossa. On the back of the ulna is a structure called the olecranon or olecranon process. This is what you lean on when your elbow is leaning on a desk. It's this olecranon process that's actually making contact with the desk you may be leaning on. This olecranon process articulates here in the olecranon fossa. So it's going to hook into the distal end of the humerus into that olecranon fossa. So again, the olecranon process of the ulna is going to articulate with the olecranon fossa of the distal humerus. Okay. Okay, let's look at the forearm. And again, you have to differentiate the posterior view from the anterior view. The posterior, when you feel the back of your elbow, you're feeling this, the olecranon process. When you look at it from the front, you see the trochlear notch, you see the head of the radius. Now, this head of the radius right here articulates with the ulna. because of this notch. There's this little notch or depression that's in the proximal ulna, and it's called a radial notch. So where is the radial notch? The radial notch is on the ulna. It's a notch. It's a little nook right here that's kind of concave that allows this rounded head of the radius to rotate. It's round for a reason, so you can supinate and pronate your forearm. Okay, so we have a trochlear of the ulna. This bump right here is the coronoid process. In the same horizontal plane as the coronoid process of the ulna is the head of the radius. Just below the head is a neck, and a little bit inferior or distal to it is a tuberosity called the radial tuberosity. The importance of the radial tuberosity is this is the attachment site for the biceps brachii. It's the attachment for the biceps brachii. So we have a radius and we have the ulna. Once you find that rounded head of the radius, you know that this is the radial bone, and the radius is the more lateral bone. In anatomical position, with your hand in the supinated position, the radius is on the thumb side. At the distal end of the radius is a large bump that we can all feel just proximal to the thumb. That bump is called the radial styloid or styloid process of the radius. It's a lot easier to just put radial styloid, okay, instead of styloid process of the radius, if you ever get that on an exam. Now, the styloid process of the radius or the radial styloid is most distal. But look where the head of the ulna or the ulnar head is. The ulnar head is distal, whereas the radial head is proximal. So they're at opposites. Okay. The other thing that's opposite, right here, the articulation between the head of the radius and the ulnar, there's a radial notch here at the proximal end. And again, remember the radial notch is in the proximal ulna. But there's going to be a distal notch, right? There's a distal notch here. That's the ulnar notch. So if the radial notch is on the ulna, then the ulnar notch is going to be on the radius. And these notches are just, they allow the radius and ulna to articulate with one another. Okay. All right, so we have the radial styloid, and you also have an ulnar styloid. It's distal to the head. It's that little bump and that little point right here. Okay, so from the posterior side, we have the olecranon process. That's the part that you lean on your elbow. You can see a little bit of the head of the radius. Here's the shaft of the radius. And here's the radial styloid, the ulnar styloid, the ulnar notch. The ulnar notch is on the radius, and the radial notch is on the ulna. You have a coronoid process here. You have an olecranon process here. So the olecranon process we see on the posterior, the coronoid process, that little bump we see on the anterior. And again, the coronoid process is going to fit perfectly into the coronoid fossa, whereas the head of the radius articulates with the radial fossa. The olecranon process fits into the olecranon fossa. Okay, now we're looking at the hand. When we look at the hand, we have to make sure that we're looking at it in anatomical position. So we're going to focus on the anterior view. When we look at the hand, you can see the thumb. The thumb is always your first digit. The pinky is the fifth digit. So we number them by Roman numeral 1, 2, 3, 4, 5. Here's the radius, the distal end of the radius and the distal end of the ulna. And then we have carpal bones. These are called carpals. And they are 2 rows. There's 8 bones total. There's 4 bones in the distal row, and there's 4 bones in the proximal row. 4 bones in the distal row, and there's 4 bones in the proximal row. Let's look at them from lateral to medial. So we're starting from the thumb, and we're going to go to the pinky side. We're going to look at the proximal row first, and then we'll look at the distal row. So in the proximal row, we have a scaphoid. Then we have a lunate. Then we have a bone called a triquetrum, which is here. You can see a little bit of the triquetrum, but the reason why you don't see the whole thing is because the pisiform is sitting on top of it. So the pisiform sits anterior to the triquetrum. But these are the 4 bones in the proximal row: scaphoid, lunate, triquetrum, and then the pisiform. The pisiform is the bone, like if you're using the mouse of a computer, the pisiform is the part of your hand that makes contact with the desk. It would kind of be equivalent to your elbow leaning on the desk. It's that part of the hand. Now, in the distal row, from lateral to medial, we have the trapezium, the trapezoid, right? The trapezium is in alignment with the first metacarpal. The trapezoid is in alignment with the second metacarpal. The capitate is aligned with the third metacarpal. And then you have the hamate that articulates with the fourth and fifth. So you have 1, 2, 3, 4. Trapezium, trapezoid, capitate, and hamate. Okay. The little silly mnemonic to remember these. Gosh, I'm going to have you look that one up. Okay. But there's some silly mnemonics. I just remember some lovers. So if you want to Google silly ways of remembering the names of the 8 carpal bones, I don't want to say it. Not that it's like really inappropriate, but some people get a little bit more sensitive than others. So I'd rather you look it up if you choose to. But some lovers is what the little acronym mnemonic starts with, and then you can find the rest. But it was a way that I remembered, gosh, 27, 28 years ago when I took and studied anatomy to remember the names of the 8 carpal bones. They are from lateral to medial, proximal row first, and then distal row, again, lateral to medial. So these are the 8 carpals. The one that fractures most commonly when you fall with an outstretched hand is the scaphoid bone. People typically have pain right in this region, severe pain, just proximal to the thumb. The one that kind of dislocates most easily is this one called the lunate. The lunate subluxates and can put pressure on the median nerve, causing carpal tunnel syndrome. Okay, so these are the carpal bones, which makes the floor of the carpal tunnel. All right, so after the carpals, there are the metacarpals. Metacarpals, right? Meta means after. So there's metacarpal 1, metacarpal 2, metacarpal 3, 4, and 5. So on an exam, if there's an arrow that's pointing to this, you have to be specific. You have to say third, like the number 3, RD, third metacarpal. If it's this one, you'd say 4, TH, fourth metacarpal. If it's here, 1, ST, first metacarpal. Okay. All right. So now finishing up, what do we have distal to the metacarpal? So you have 8 carpals, you have 5 metacarpals, and then we have what are called phalanges. Now, distal to the metacarpals, if I zoom in here, you can see that we have a proximal, a middle, and a distal phalange. We have a proximal, a middle, and a distal phalange. A proximal, middle, and distal phalange. Proximal, middle, and distal phalange. Again, you would have to be specific. So if we pointed here, you would say third proximal phalange. If I pointed here, you would say third middle phalange. If I pointed here, you would say third distal phalange. If I pointed here, you would say fifth proximal phalange. If I pointed here, fifth middle phalange and fifth distal phalange. So we have a proximal, middle, and distal phalange from digits 2 to digit 5. Well, what does the thumb have? The thumb, if we zoom in, it only has a proximal phalange and a distal phalange, or proximal phalanx and distal phalanx. There is no middle phalange of the thumb. The thumb has a metacarpal, and then it has a proximal and a distal phalanx. There is no middle phalange. Okay, that brings a close